the next speaker I would like to introduce is Dr. Rojas, who is going to speak to us about cognitive changes with chemotherapy and cancer treatments. Dr. Rojas works in the Memory and Aging Clinic here at UCSF and certainly has seen a lot of our patients for evaluation for cognitive changes after cancer treatments. So I'd like you to welcome Dr. Rojas.
Can you hear me? All right, thank you. Well, thank you all for being here, and thank you for giving me the opportunity to share these thoughts about brain and cognition. Let me start by saying or making emphasis on this fact that the brain is it's an organ that depends a lot on energy. A lot of the symptoms that we see after cancer treatments or after cancer diagnosis rely or come from disturbances in how the brain copes with energy. About 20% of the blood flow, or the blood that comes out from the heart with every beat, is captured by the brain. The extraction of oxygen and nutrients is probably one of the highest in the body, probably just second to organs like thyroid, or if not addressed by muscles. And about 50% of all the energy that is used by the cells in the brain is used to maintain the excitability of cells in the brain. So because of its energy dependent features, the brain is one of the organs that is particularly vulnerable to all the effects associated with cancer and the treatments. Now, the brain is I see it as the most fascinating piece of organized matter in the universe, in the non-universe. We're still trying to understand it. And, it's designed for things that we are not aware of, but they're happening in our body, controlling things like, internal rhythms for sleep, blood pressure, breathing. All this is regulated by the brain, but also the brain is responsible for how we interact with the environment, how we respond, how we plan movements, how we manipulate objects, how we perceive the world, how we, feel things just by touch or with our spatial senses. Also, comportment, how we interact with others, communication, problem solving, personality, feelings, imagination, creativity, our aspirations, our dreams, everything is happening in the brain. And these are very complex events, and even the minor disturbance in energy can impact all of this. And sometimes the arrangements that happen with cancer or with treatments happen in all of them at the same time. So this could affect quality of life significantly. So I like to think about cognitive function as this scale or a very stable situation where cognitive function is dependent on our general health, especially cardiovascular health. If there's any disease like blood pressure or diabetes, or even chronic pain, for example, for other reasons, chronic joint pain, that could have an impact on cognition. So general health is important to maintain cognitive function. Our genetic constitution also has an impact. We don't have a lot to say or a lot of ways to manipulate this, but this is what it is. This is a fact. Our genes determine our cognitive function in certain ways. Also, our education. It is known that people who have more than 10 years or 12 years of education have lower risks of progressing to cognitive decline with age, especially. And there is observational data that things, for example, like speaking more than one language could be a protective factor against cognitive decline, independent of cancer or treatments, but just with age. And then other things that may impact are the social environment. And just being in a stressful situation, or difficult neighborhoods, or stress at work, or in your daily life, that's a burden. It's a kind of a load that is all the time there on the brain, and that can impact cognition too. So, but if we have the right situation, our cognition is very likely to be stable. Now, on the other side, shifting or trying to destabilize the system, we have default insults that are happening all the time, and one of them is aging. We know for a fact that there's some cognitive decline with aging. That's normal. That's part of normal physiology, and it happens to a certain extent. And then just living, meaning all the physiological processes that happen, just like digesting food, for example, or even breathing, actually, that by itself is a stressor. There's some oxidative stress happening, and that's a kind of continuous injury that is affecting the brain. And the fact is, biological systems are prone to oxidation. You put an apple, just there for days, and it tends to oxidize. All our processor, the chemistry in our body tends towards oxidation, just because our biology is based on an environment where there's a lot of oxygen. So that is a little bit of stress that is always impacting our cognitive function, especially with time. And we don't want a lot of oxidative stress. Unfortunately, with chemotherapy, there's a lot of that. There's a lot of the amount of oxidative stress that affects the brain with chemotherapy is significant. And this happens in a number of ways, but basically it has to do with the chemistry itself of the compounds, and how that affects metabolism in the body, but especially in the brain. And then not only chemotherapy, but radiation can also be a big problem. We may think that only radiation that goes to the brain, for example, or to the head, when you are trying to treat a brain tumor or a metastasis, or seeding that goes to the brain, and you get radiation, that radiation will be particularly bad. And radiation in other parts of the body will not affect the body, but we know from our experience with patients and with experiments with animals that radiation, even if it's away from the brain, if it's in the chest, for example, or in a limb, that will also have an impact on cognition. And then cancer itself, not necessarily the treatment of cancer, but just having a diagnosis of cancer. The chemistry of the body changes a lot with a tumor present. The body's trying to react to it, to control it, and that causes a lot of oxidative stress that has an impact on cognition. And there are specific cases, some tumors that intrinsically they produce hormones and they produce some chemicals that have a number of effects, and that could also impact the brain directly. And then the body trying to react to them. There are certain conditions where the response to the tumor can be problematic. And this is I make emphasis of this because when we're dealing with cognition after a diagnosis of cancer or treatment, we hear the chemo fog, right? Like being in a fog for the brain, or the chemo brain, but it's actually a misnomer. We think of it as not only chemotherapy, but all the other things that are happening, especially the diagnosis of cancer itself. And also the idea of dealing with a diagnosis of cancer is a stressful, situation. You may not even have cancer, but just the idea of possibly dealing with a diagnosis, that increases the cognitive load, the burden of worrying, and that by itself can destabilize the system and cause cognitive problems. So the brain unit, or the unit of function for the brain, is this cell, the neuron. And basically there are two elements. The neurons are specialized to process information, compute information and process information in space and time. And they communicate through chemical messages or electrical messages. So the bottom line for the body is to maintain that excitability and the ability to communicate and compute at the maximal rate. And there are two elements in the neuron that is very important. So the neuron has a body here, and there are extensions that allow the neurons to communicate with each other. And there are these elements here, the mitochondria. These are organelles that are the powerhouses of the cell. That's where the cell, or the energy in the cell is produced, and is very important for the cell to have a lot of mitochondria. Mitochondria can divide and reproduce depending on the demand, the energy demands in the cell. And also there is, in these extensions of cells, there's like an insulator around them. The insulator is made out of fatty tissue and proteins, and that increases the efficiency of electrical transmission. And both of these elements, the mitochondria and the myelin, are particularly vulnerable to chemotherapy. The chemistry of these entities can be altered by chemotherapy or radiation, and sometimes by substances produced by the tumor. So when there's excitation, there's transmission of energy. That's what we want to maintain. But when they started using chemotherapy about 50 years ago or 60 years ago, they noticed that there were cognitive changes in patients, and they initially said, well, it's psychological. It's just a new environment. It's all stress related. But we know for a fact now that the chemistry of neurons change, and the cognitive changes occur because it's not working properly. And this is an example. This is a brain, and these are kind of hotspots of neuronal structure. And these two hotspots are very important for processing information in the brain. And we know that these two spots are particularly vulnerable to damage after chemotherapy. And just bear with me, with these two graphs, what we have is, in this axis over here is the integrity, how well preserved the structure, the cells are. Over here is more better preservation of structure, and here is less. And on this side, we have the same patients, how the structure of the brain is before treatment, after treatment, 3 months after treatment, and 3 years after treatment. And look what happens. So before treatment, the structure of these two spots here is very well preserved. The integrity is high. And then after treatment, it goes down significantly. But then, even without doing anything, 3 years later, you check integrity again, and the integrity of these structures in the brain is restored. And that happens in two different spots of the brain. And this is very encouraging because it kind of counteracts the idea or the notion that we had that if you damage the brain, it's damage that is done, that the brain doesn't regenerate and the cells don't divide again, and brain injury is permanent. But this tells us something different, that this is very encouraging. We actually can expect that there can be some regeneration of the structure and hopefully of function too. And there might be some ways that we can affect this or facilitate this process of recovery. So this is great, and I want you to keep that in mind. So we don't know exactly how much or how common cognitive function or cognitive dysfunction is in cancer after treatment. Most of the information that we have comes from studies in breast cancer. And the estimates vary a lot, but we estimate that it's about this number, 75% with some sort of cognitive change. And there's a wide variation. It could be something like just a very subtle change in the effort for cognition. I just have to concentrate more. I just have to pay more attention, or maybe reread that paragraph a couple of times just to really get there. But also can be a lot of other things, more difficulty with attention. People say I tend to I just cannot concentrate on that TV show anymore. I just tend to start thinking about other things, or I have problems planning, problems organizing around, papers start to pile up, problems multitasking, doing a couple of things at the same time. You don't interrupt me when I'm loading the dishwasher because I'm going to do it wrong. So also just difficulties completing tasks in general. And some people also report difficulties learning new things. I just have a problem, remembering that address, or I have problems coming up with names of people. I know them, or I was introduced to them and I didn't get the name, Or could be more severe, like I know that people, or those people from long time ago, and I just cannot remember their names. And some of these problems can be so severe that people have serious problems functioning in life, and they need support. Most of these, some of these cognitive problems, and this is evidence to show that it's not only the chemotherapy or the radiation, but before the treatments, about this percentage of people, 35%, already reported there's some cognitive change. As I said before, the cognitive change can be so severe that sometimes people cannot go back to work. We don't know how much or how long these cognitive changes last. We know, for example, that they usually appear during treatment. They're more selling during treatment and tend to last for a few weeks after treatment. But some studies have shown that people report cognitive changes even years, 10 years or 20 years after having a treatment for cancer. So we're still trying to characterize and learn how this is impacting function and life. But there are estimates that about 8% of people, cannot return to work, for example, after a diagnosis of cancer. So there are a few things that we can do to try to reverse these cognitive changes. And our responsibility as healthcare providers is to try to understand it better, and hopefully in the future we'll have more information. But I want you to take these 6 strategies that we always keep in mind and things that you can implement to, with cognitive changes. And you're going to hear a lot about this today. Other presentations will emphasize. So I'm just going to briefly go through it and say what's relevant for the brain. We unfortunately don't have a specific treatment that we can offer that is devised or designed only for patients after chemotherapy. So all of these recommendations are an extension of what we recommend in our clinic, for people with cognitive decline. Mostly cognitive decline due to aging or cognitive decline due to some neurodegenerative process. So the first point is diet. Diet is very important. The best diet that we have for in our clinic in cognitive decline, people risk of cognitive decline it comes from the Mediterranean diet, and you probably heard about it. There are no trials or data coming from an actual experiment, but this is just from observation, what people eat. And the Mediterranean diet basically features low red meat, or less than 1 portion per week or less, and high in fish, things that contain omega-3 fatty acids, 2 or 3 portions a week, and then a lot of vegetables, not necessarily fruits, but vegetables. This is a portion of food, so 5 of those. Apparently our bodies are evolved to process 5 to 10 of these, and if we don't do it daily, we don't need to get there by tomorrow, but it should be a goal of having 5 portions of vegetables a day. And then dry nuts, olive oil, and not animal oil, and not processed sugars, low salt. Wine is you probably heard about the French paradox, meaning people who consume more wine tend to have long-term less risk of cognitive decline or less risk of cardiovascular problems. And that's true. The recommendation still holds for general terms, 2 glasses of wine a day for men and 1 glass of wine for women is what we usually recommend. Wine is preferred over liquor or beer, and red wine especially over white wine because of the chemical content, the antioxidant. And it's kind of the idea of putting the body to this a little amount of stress all the time, so the body doesn't lose the it's like kind of a little of training for the body. But it might not work necessarily after cancer. And being a little spicy, if you want to say, alcohol is a neurotoxin, period. So if you can cut back on alcohol, I would probably do it, especially if you're already having cognitive changes. I would not start drinking alcohol because we think that might help. And then maintaining a stable weight, a stable diet is important for cognition. We know that people who lose weight quickly are at increased risk of cognitive decline. And then the second point is exercise, physical activity. Again, we don't know much about how much is good, how much is recommended, but we go by, for cognitive purpose, how much is recommended for cognitive purposes, but we go by the recommendations of the American Heart Association. And this is a program of exercise, 30 to 45 minutes per day, moderate to intense. That means something that makes you sweat, that makes you tired, that gets your heart pumping and going. Most days of the week, preferentially under the supervision of a personal trainer, because she's going to make sure that you're getting to your goals and you're not going to injure yourself. And she's going to give you exercises that are appropriate for what you can do. And again, this is something that you don't need to get there by next week. You can start by doing 1 day a week, and then you increase the dose slowly. We are actually starting to run trials on specific doses of exercise, meaning minutes of exercise or how many calories you burn in an exercise session and try to see the effects on cognitive function. So physical activity, especially aerobic activity, is important. It's not the same as lifting weights probably, but something aerobic. Again, something that gets your heart going. And another very important aspect is good sleep. When we sleep and we reach deep stages of sleep, when we are deeply sleeping, there are a lot of good things that happen in the brain. A lot of the neurotransmitters, the chemicals in the brain get kind of restored. A lot of the storage of memories happens during sleep. What we call consolidation of information gets really, really stored in different parts of the brain. And at the chemical level, some of the substances or some of the proteins that are having linked to cognitive decline, for example, in Alzheimer's disease, the amyloid protein that accumulates in the brain and seems to cause some degeneration of cells. A lot of clearance of that protein naturally by other cells in the brain happens during deep stages of sleep. So it's very important that we do everything in our hands to have good, solid, restoring sleep every night. And fortunately, you may be dealing with cognitive decline, cognitive problems because of cancer or treatments, but fortunately, you don't have to live with that and with sleeping problems. Fortunately, I think we have very good means of addressing sleep problems. And this thing starts by having a good hygiene for sleep. Going at the bed, having a structure for going to sleep at the same time every day. Having a good environment to sleep without light, without a lot of noise. Actually, for some people, it's the opposite. Some people actually need a little bit of noise or some level of illumination to sleep, and whatever works for that person should be implemented. And then have consistency in our patterns. If you tend to have a nap during the day, it should not be a long nap. And using bed only for creating a habit of psychological association between being in bed and sleeping, and not being in bed and looking at a tablet or reading, because that can create some problem of habit basically. And also sometimes you need a sleeping aid, and that's okay. It's important to do it under the supervision of a physician, because some sleeping aids may cause more cognitive problems. So we can help you select a sleeping aid that is not going to impact a lot on your cognition. Sometimes the sleep problem comes from other issues that are not associated with cancer, and it's important to have that addressed. Because, for example, sleep apnea is a big problem, and even if you're lean, even if you're not overweight, you can have periods of not introducing air into your body while you're sleeping and you don't know it, and that could be by itself just a cause of cognitive problems. So it's very important that if you have problems sleeping, if you feel you wake up in the morning and you don't feel like you're well rested, it's important to pay attention to that and bring it up when you see your doctor. So number 3 and number 4, social activity, social interaction, social engagement. People ask a lot this question: what can I do in terms of training for the brain to maintain my cognition? And it's counterintuitive, because if we want to bring more muscle mass, we want to increase our bulk, what we do is a lot of reps, right? We just go to the gym and start doing it over and over, and then you have a big routine. It's not the same for the brain, unfortunately. If you do more memory tests and more exercises of learning and putting your Sudoku down and addressing all those all the different tablet-based programs for improving cognition, it's probably not going to be the same, because the brain doesn't work like that. If you do it a lot, you probably create more stress. You may get very good at doing those games and those tests, but that will probably not transfer for other activities, solving problems in real life. So what I recommend is, especially being in a social environment, an environment that is pleasurable. And that has a biological explanation. Being interactive socially in communication activates certain patterns of activity in the brain, and that is like doing stretching for the brain or yoga. Imagine, being in a social interaction creates this activity that gets the brain moving in a way. And that's much better than any Sudoku or any brain training thing that you can do, as far as we know. We might learn more about that in the future. So if you like Sudoku, if you like doing those training games, you should do them as long as they're not stressful. Playing games as long as they're not stressful. And then a very important recommendation here is reducing the cognitive load, and this was mentioned before. Sometimes after cancer or after chemotherapy, you may see the patient gets or you as a patient feel that you are more on someone is taking care of you all the time, and that's okay. What we recommend is to reduce the cognitive load, and this comes in different many ways. Just facilitating the information, using the information, making everything available, relying on notes on a big calendar to keep track of days. That's okay. Delegating stuff to people around you. That's okay. We encourage that. Doing one thing at a time and only doing things that are pleasurable and that are easy for you. That's okay. That's very encouraged. Because if you try to take care of everything yourself, it creates a kind of a vicious loop. You have problems, and those problems create stress, and then because you're stressed, you have more problems doing it, and you have to break down the cycle somewhere, and it starts by delegating things, and we hope it's temporary in the majority of cases. So it's okay, and we encourage to do that. Reduce the cognitive load, reduce the amount of information that you have to deal with. And then medication. So we don't have medications specifically designed to treat cognitive changes after chemotherapy. But we can start, for example, by clearing all the medications that can have potential side effects for cognition. And there are a lot of over-the-counter medications that can do that, especially cold remedies and or things, for example, to treat incontinence. Sometimes are prescribed as part of what we do to help, as part of side effects of cancer or treatments. But we have to be very careful, and it's good to always talk to your doctor about what medications you can cut down that may be worsening your cognition. And even though we don't have particular treatments for cognition, just by anecdote, a lot of doctors use certain medications that we use for other reasons, and we try to help cognitive changes in after cancer or treatment by using these medications, even though they're not approved. But there are some anecdotes that sometimes people improve, And this could be medication, for example, that we treat in Alzheimer, we use in Alzheimer's disease to boost memory and boost attention, or medication that we use in attention deficit disorder to, again, increase attention or boost attention, or medications that we use for mood issues, like antidepressants. Some antidepressants, just by making you feel better about yourself and making, breaking the sadness, can help you engage better. So those are things that are actually used a lot, and a lot of patients that I see in clinic are already using some of these, and sometimes we recommend using them. And I cannot tell how effective they are, but because they are relatively safe, we can use them. So it's an option that it can be considered. And also there's some, as neurologists, we sometimes are the laughing stock of doctors, because they say, you guys don't cure anything. You may tell us, or about 50% of the time you might be wrong, or you might be right about what you say it's happening, but you don't necessarily cure anything. I hope that will change. Yeah, they say you are the science of the MRI and goodbye, or the diagnose and adios. But I hope that will change soon. For example, there's an example for cancer. This drug ifosfamide is used to treat soft tissue cancers. And some people that get this chemotherapy, ifosfamide, get an encephalopathy, very, very severe changing orientation and arousal, and could be dangerous. Some people need ICU stay because of the cognitive changes. And there is this compound, methylene blue, that was successfully used to prevent or reverse the effects of this encephalopathy caused by ifosfamide. And this was because ifosfamide, when it enters the body, produces a chemical that goes to the brain, goes to mitochondria, and impairs the energy production in mitochondria. And methylene blue, what it does is an antioxidant, but it also it acts as a shuttle in mitochondria to keep the energy processing going. So people who got methylene blue, at least in these small trials, had cognitive changes that were less dramatic and lasted less. So we hope that's an example. We hope this is sort of a medication that maybe we'll be using in the future as we understand better how this is happening. And then there are a lot of clinical trials going on. I couldn't find one that is in our area, but I hope that in the future we'll have more of these interventions. So if you're interested, keep an eye on this website. This is it's a government website. All the clinical trials that are approved by, let's say, the government agencies are registered there. And you see all the different things that they're trying to improve cognition. This is all in cancer populations. Just from doses of physical therapy, specific cognitive therapy, or electrical current, acupuncture, stress reduction, cycling, doses of exercise by cycling, nicotine, not necessarily smoking, but just the nicotine, and then light exposure, and a different number of medications that are already used and we're exploring. There's good evidence in animals, but so I think things are going to get better and better in terms of things that we can do in terms of treatment. And then another important piece of advice is we tend to attribute a lot of cognitive changes after cancer or treatment to the treatment or the cancer, but we've been surprised. So if the cognitive impairment is very severe, or if it lasts more than 6 months and is very disabling, the recommendation is that that person gets a neurocognitive evaluation, seen by a neurologist or a psychiatrist. Because again, we have been surprised. We've gotten patients that the changes are attributed to cancer or the treatment side effects, but there's something else going on. And this is very important that it's addressed, because the change could be potentially reversible, or sometimes we've had cases where the diagnosis is actually Alzheimer's disease, and that's important also to consider for in case there's a need for further treatment for cancer. Things change a little bit, so keep this in mind. So in conclusion, cognitive changes after cancer are very common, and there are a lot of things that we can do to improve cognition. the changes are based on changes in the brain and changes based on how the energy manipulation in the brain happens. And I hope this was a useful set of information. And if you have questions, please, I'll be happy to address those or comment.
Thank you, Dr. Rojas. That was great, and I think that provides a lot of insight into some things that we can do to help with cognitive function. I did have one quick question from the audience. How are cognitive changes measured or tested to see if the brain cells have been affected?
Yeah, very important question. Yeah, absolutely. So you saw that diagram. I had all these cognitive functions. We are not that good at measuring all of them, unfortunately, in the clinic. In the clinic, we have a battery of questions that may last like an hour or so. And we check 4 domains, 4 big domains: memory, language, visual-spatial processing, and executive function. Executive function is all those functions that allow us to pay attention, concentrate, plan, organize, multitask, solve problems, lateral thinking. So basically, task-oriented processes. It's artificial, and we get an idea of what changes. But the good part is that we can repeat that over time and see what the track or the trajectory of change is. It is important to do it still, even though it's not perfect, because I think it helps to tell when there's a change compared to people your age, that have no cognitive problems.
And two other questions regarding the slide that you had up earlier. The graph showing the post 3 months and then post 3 years treatment. Some questions about what type of treatment those patients had, chemotherapy, radiation, or both, if you know that.
Yeah, those patients were actually young patients that were treated for breast cancer. So all of them got chemotherapy only, and the group was small, so it was not a big cohort. But what is remarkable is that the change that was seen 3 years later, even though there was a change in the structure after 3 months, the change after 3 years happened without any intervention. That was just a matter of time, basically.
Great. Thank you so much.